It's my pleasure to introduce Dr. Wendy Kelso. Wendy's been instrumental in organising today. Wendy is a senior clinical neuropsychologist at neuropsychiatry here at the Royal Melbourne, and was a clinical lead on our Better Care Victoria Neuropsychology telehealth project called Bright Yod. She was instrumental in establishing our Melbourne Young Onset Dementia Service, which is a clinic specifically designed to assist patients and families with young onset dementia. She's also a frontotemporal dementia support group facilitator with Dementia Australia, and has worked with people with FTD for over 15 years. Thank you, Wendy. Just swap seats.
Thanks, everyone. So what we're going to do now is I'm going to play a video, and this video is Billy, and Billy's 29 years old and the primary carer for his father, who was diagnosed with behavioural variant FTD in 2018. So Billy's father deteriorated quite rapidly and is now in permanent care. And in his video, Billy reflects on the road to diagnosis and what the experience was like for the child of a parent with FTD.
Hi, my name's Billy. I'm from Sydney, Australia. My father got diagnosed with FTD, behavioural variant, in the beginning of 2017. I was 26 at the time. I was living in Melbourne, and I got a phone call from his GP saying that my dad has some mental health issues, and through an MRI it showed that he had some changes in his brain, and we quickly found out that he had FTD. As a 26-year-old, I then realised that my dad probably hadn't been functioning well for quite a while, and it didn't occur to me what the problem was. I just thought my dad's getting a bit older and a bit more senile. The first sort of symptoms that I realised was that my dad became more introverted and excluded himself from social activities. Although my dad was presented very well, he was very healthy, and I started going to social things without him as a 16-year-old, 17. And it got to the point where my dad didn't really know what I was doing at school, and I finished school and he didn't come to my graduation. And it wasn't like he didn't care, he just seemed a bit sort of senile and couldn't really think or organise beyond his own little life. So fast forwarding from that, he ended up engaging in another relationship which didn't work out too well, and as time went on, my dad started hoarding things, collecting things without any explanation. He couldn't explain why he was collecting things, and he was very strong with routine, and he did the same things every day, the same walks, the same places, and he kept up. As his FTD became worse, he actually became more active and went for really long walks, to the point where he would walk all day and come back and forget where he'd been. And that's where I decided that it was probably time to basically institutionalize him, because he wasn't safe on the roads. He was running across streets and not paying attention to the traffic and things like that. Yeah, it's been a fairly difficult journey, particularly with my dad. With dementia being loss of personality, a personality disruption in his personality. I mean, that's very difficult to deal with, particularly when it's happening over time and gradually getting worse. So for a young person like myself, trying to find my own identity. Having a single parent who is also gradually, who's actually getting worse, and they don't even know who they are as a person. It's difficult to get your head around. I was in a dark spot for the last 3 years, trying to figure out how to deal with my dad and all the social issues that he got himself into, particularly with his with another relationship, and me being the sole carer with no family support. Yes, it was really difficult. I eventually put my dad into a nursing home, and probably the worst experience that I've ever had in my life so far. And I eventually just had to accept that's what it is, and I did the best thing that anyone could have done. And I did have to realise that I had to look after myself. That's extremely important. And I found some people that gave me some good advice, that I had to look after myself, and my dad wouldn't have wanted me to suffer trying to look after him for the next however many years he lives. Work wasn't easy to do, particularly when I wasn't in a good headspace, and I was fluffing around for about a year, and I just had to get things together. I managed to find some things I was passionate about, and I committed to that, kept myself healthy, and now I've got a fairly promising trajectory, and I'm pretty happy with where I am and where I'm going. So I think it's important to not get too involved with your emotions, particularly when you can't do anything about the situation. And I think it's extremely important to look at your own future as a carer, and realise that you have far more potential than the person you're caring for, and that person you're caring for wants you to succeed in life. So I guess that's probably my last bit of advice, is to do as much as you can for the person you're caring for, but also that can't limit you as a person and your relationship with other people, your friends, and your wider community.
I'm going to talk about managing behavioural changes in FTD. And Sarah Farrand, who's one of the psychiatrists, unfortunately is unwell today, so I'll just be talking by myself. Okay. The first thing that I just want to quickly talk about is Olivier has mentioned already the changes in the brain that occur in behavioural variant FTD, but I just want to talk about, you can see here the frontal lobes. So they're the main areas where there's so responsible for controlling personality and behaviour, and particularly things like planning, problem solving and decision making. And also the temporal lobe down here, where is affected in semantic dementia, where people have difficulties understanding the meaning of the word, understanding language, but it also controls your emotional systems. Just going to briefly talk about this picture here. So this is looking at the spectrum of frontotemporal dementia. And I know on the chat there's been a couple of questions about PSP, so progressive supranuclear palsy, and corticobasal degeneration. Now they're considered forms of frontotemporal dementia, just like semantic dementia and progressive non-fluent aphasia are. And even some variants of motor neuron disease can have frontotemporal dementia that coexist with them. So you can see here on this little continuum tree that depending on what type of frontotemporal dementia you have, you may have different cognitive symptoms, different behavioural symptoms, different psychiatric symptoms, and different language symptoms. And I'm going to go through some of that today. Probably the most important thing to realise is that the behavioural changes that occur in frontotemporal dementia are due to brain changes. And many people find that they may have a tendency to blame the person with dementia, and really it's the disease that's causing all the symptoms. And that can be incredibly difficult if you're caring for someone with FTD, not to blame the person when it's extremely stressful or there's heated arguments, but it's always good if you can try in moments of calm to try and remember that it's actually the disease that's causing these changes. So, as I was talking about before, it's a little bit like just having a broken leg, but the person's brain is broken. It's not working the same. And because of the loss of brain cells that occur, particularly in the frontotemporal lobes, they cause the symptoms of FTD. There's ways of managing the behaviours, and we've often found as well that carers sometimes find that they're also blamed for the person with FTD symptoms because they can't actually manage some of the behaviour out in the community. So it goes both ways. The person with FTD often gets blamed for the behavioural symptoms, but sometimes family members can also get blamed if they start behaving in an inappropriate or antisocial way in the community, and many family members don't know how to basically fix it so they can go out on social outings. Okay. I'm going to talk a little bit about caring and personality types in FTD now. So some people are born carers, and Dana's going to cover this a little bit more in her talk with Sam this afternoon. And some others are not suited to the caring role. So you need to think carefully and honestly about yourself and about your own strengths and limitations. So why are you the carer? So are you the carer because of love, duty, obligation, is it guilt, expectation, financial, or there's no one else available? What contributes to behaviour? So relationship with the person prior to the illness is one of the main things. Belief systems and values. So some people, for example, maybe from a religious background, or they have a cultural way where they think people should behave in a certain way. And if the person with FTD breaks those rules, it can be harder to manage. Also things such as physical and emotional burnout can affect behaviour. And sometimes if the carer is finding that they're extremely stressed or extremely tired, that they therefore can't manage their behaviour as well and their interactions with the person with FTD. Expectations, levels of stress, worry, burnout, and the amount of support the person has to look after the person with FTD. Another thing is education. So if you understand why the person is having the behavioural changes, it can assist then in trying to manage some of those behaviours. The most important thing is to remember the person. Yeah. So remember what they were like before they started to develop the illness. And I think that can be extremely easy to forget when there's lots and lots of difficult behaviour changes, and the person with FTD may not represent who you married or who you were looking after before, and that can be really, really difficult. Try not to take the behaviour personally, and if you can, use humour. And I know that that can be really difficult, but sometimes it is so difficult that if you didn't laugh, you'd cry. Remain as calm as you can, and we often find that if someone's in a predictable routine that they can cope much better, because it takes the demands off their brain, so they don't have to, the cognitive load is reduced. So for example, if someone has frontotemporal dementia, it means that because of the loss of brain cells, they find a lot of tasks more difficult than they did before. So if you try and keep things predictable and stable every day, then it takes off that cognitive load so they can actually act and act at a higher level and be a bit more effective in accomplishing some of the tasks that they'd like to do. You essentially need to act as their frontal lobes because their frontal lobes isn't working as well as it did before. And if possible, keep them involved in activities and hobbies that they've really enjoyed in the past and maintain connections with family and friends. Okay. Now, this is a little bit of a behaviour chart. So what do you do when the behaviours are difficult? So if the behaviour is not harmful, is it possible that you can accept the behaviour as part of the illness? It may not be desirable, but if it's not harmful, is it possible that you can change your expectations and be a tiny bit more tolerant and accept the behaviour as part of the illness? Sometimes that's possible and sometimes it's not. So if it is possible, you can focus on the remaining abilities. But if it's not possible, can you alter your response, possibly increase your tolerance, reduce your expectations, or modify your own behaviour? And can you develop a list of strategies and make a plan, or modify your environment to try and stop the behaviour from occurring? And we often find distracting and reassuring the person and changing the routine can be very useful. So what is cognition? So when Olivier was talking before, he was going through all the different areas of the brain that are affected in FTD, and many different cognitive skills are affected. Sometimes, though, in the early stages of FTD, the person isn't diagnosed, particularly the behavioural variant, for quite later on in the journey, because the behaviour changes are very prominent, but they actually do quite well on cognitive testing. And we often talk about a white coat syndrome, where they may go to the doctor, for example, and they can actually behave quite well for that half-an-hour appointment, but then when they leave the room, then some of the behaviours come out as well. And some neuropsychological tests aren't very sensitive at picking up behavioural and changes in what we call social cognition, and they're more useful at picking up things such as memory difficulties or planning and problem-solving difficulties. So what are some of the changes that happen in BBFTD? So Olivier and Dennis and Dharma and Clem have touched on this a little bit before. The biggest, particularly for behavioural variant FTD, is personality change. So the person isn't able to demonstrate as much emotion as they did in the past, and their ability to empathise with the person that they're living with, or with their children, or with their parents and friends, is reduced. The warmth and understanding and ability to put themselves in the other person's shoes is really limited. And there may also be a change in loss of intimate relations, so in sexual relations, for example, but even in physical touch. And a lot of people with FTD, while we hear often about people being very disinhibited, often they're also apathetic, and the most common sexual changes are actually no interest in sex, no interest in tenderness or physical affection, rather than too much interest. Often they become quite self-centered and inflexible, and it may mean that they get stuck on a certain train of thought, and a little bit like they're on one set of train tracks and they cannot divert their thinking to go on a different train track to get to a different line of thought or a different problem or a goal, for example. And people with BVFTD, usually one of the first symptoms is a lack of insight, that they're not aware that they've got these changes, but everyone around them is. Now that's a little bit different for the language variants, and I'll come and talk about in a sec. Some of the other behaviours are social avoidance, so not wanting to go out and be in social situations anymore, or if they are in social situations, not being able to behave the same way that they did in the past. What we call perseveration, which means doing the same thing over and over again. For example, they may be wanting to listen to the same music over and over again, or eat the same food, or say the same couple of phrases under their under their tongue, for example, over and over. So things that they do very regularly in a very fixed and repetitive type of way. Gluttony is often a feature as well, where people overeat, particularly sweet food, but it can also be salty food, and even non-food items such as soap, for example, where people just stuff food in their mouth, often swallow before they've actually chewed it particularly well, and this can be a real difficulty for families. And it may be that you go out socially with someone and the person with BVFTD may steal food from another person's plate, and that can be really hard for families to manage. Apathy is an extremely common symptom in BVFTD, and I'll talk about that a little bit later. And this can all lead to relationship stress. Some of the less well-known features of frontotemporal dementia are changes in temperature and sensation, and some of the Frontier group and people across the world have been looking at particularly eating behaviours, but also ability to feel pain and regulate pain, feel if it's hot or cold, for example, and also understand their bodily sensations. So you may find that some people with BVFTD, for example, find that it's extremely cold outside. They feel that it's cold outside, even though it might be a 35-degree day, and they might put on 20 jumpers and a coat on top, and the family are thinking, oh my goodness, what's going on? But they're so inflexible that they refuse to actually take the jumpers off. So they aren't able to regulate their temperature the same way or feel and experience temperature the way that people that don't have FTD do. People with BV-FTD and also semantic dementia can find it difficult to read emotions, and this also occurs in progressive non-fluent aphasia and in PSP and corticobasal and some of the other behavioural variants that we mentioned before. So it means that they don't have the same ability to recognise particularly negative emotions as other people do, and I'll come to a slide on that in a second. They're also unable to recognise the signals to stop a behaviour. So, for example, they may hug a stranger, or they may go up to someone, for example, in their street, or ask their church minister about their sex life, you know, not knowing what's appropriate social behaviour in a certain setting and not knowing when to stop. So a lot of people with BV-FTD can be very intrusive into personal space. They can be right next to you the whole time, not realising that you need a little bit of space, and families find that really hard. Sometimes they lose their moral code or judgment and make decisions that probably are not wise. So, for example, we've seen lots of people over the years that they may have a huge increase in spending. They may start buying a lot of alcohol. They may start having affairs with other people, which they would never have done in the past before the brain changes occurred. And ability to understand sarcasm is also reduced. So we find with people with BV-FTD that you have to talk to them directly in clear language for them to be able to understand, because they don't pick up the subtleties of sarcasm. So this is a slide here looking at the ability to read emotions. So you can see here there's sadness, anger, happiness, disgust, surprise, and fear. And there's been some studies done, particularly in Sydney. Fiona Comfort's group has done a lot of work in social cognition, same with Olivier and John, just looking about which emotions can people with frontotemporal dementia pick up and which can't they. They're able to recognise happy emotions and positive emotions much more easily than negative emotions. So, for example, sadness, anger, disgust, and fear, they find much harder to read that facial expression. So if you're feeling sad yourself or you're feeling very angry, the person with BV-FTD in the room with you may not recognise that facial emotion. So they may actually have to tell them in words or express in another way the way you're feeling so they understand. This is a study that Fiona Comfort did in 2011, just looking at recognition of emotion in FTD, and it looked at a variety of variants. So behavioural variant, semantic dementia, and progressive non-fluent aphasia. And this is anger, disgust, fear, sadness, surprise, and happiness down the bottom. Blue is the control, green is behavioural variant FTD, the yellow is semantic dementia, and the purple is progressive non-fluent aphasia. So you can see in terms of people's ability to be able to identify the facial emotions, in both, for example, in anger, virtually all three types of FTD, it's reduced. Disgust, particularly BV-FTD and semantic dementia, and fear, you can see all of them have difficulty recognising fear. Sadness, surprise, but they can recognise happiness. So it's really the negative emotions they have more difficulty with. One of the questions before was about semantic dementia and what are the changes in behaviour, but also psychiatric changes that people notice. Traditionally, people did a lot of research in semantic dementia and progressive non-fluent aphasia and focused very much on the language features of the condition, but didn't focus as much on the behavioural changes or the psychiatric changes, emotional changes. But the more research that's been coming out now shows, particularly in semantic dementia, and as the disease progresses more into the frontal lobes as well, that they have quite similar level of behavioural change as behavioural variant FTD, but slightly different characteristics. So particularly in the right side, it's semantic dementia, people lose the ability to recognise faces. Often there's a preoccupation with jigsaws and puzzles and picking up, for example, cutting up newspapers to pick out a certain thing each day, or unusual kind of repetitive interests. There's often a narrowing of interests, and it can be a little bit like in autism, where they get fixated on a certain thing, like picking up fluff off the ground or emptying rubbish bins or doing a range of different things. And that can be really difficult for families to manage. Clock watching happens a lot, so people find that they're extremely regimented with time, and they may have to have their meals exactly at 5 o'clock or exactly at 12 o'clock, or they have to leave exactly to get the 3:15 train, and they cannot be distracted by that. And there's lots of compulsions and rigidity in somatic dementia, particularly regarding food, particular types of food that they will and won't eat, and activity. And somatic dementia as well, because they lose the understanding of the meaning of language, it can be hard for them to express their feeling of body change. So some people also have somatic symptoms that they can't explain as well, such as headaches or changes in sensation in their body, which they find it much more difficult to explain. And with the food, in both somatic dementia and behavioural variant FTD, a lot of the, it's the quality of the food that they love, the intensity of the taste that goes to the reward system. So they tend to crave sweeter foods because it's much higher, more pleasurable in terms of rewards, and it gives you a bit of a hit, like a drug, I suppose, in your brain. And the same with really salty foods or something they need the actual flavour of the food to be stronger, but they also need it to be extremely pleasurable. So foods, for example, like cauliflower or turnip, which can have quite a bitter taste, they're very turned off by. With progressive non-fluent aphasia, that's where there's a decline in ability to be able to express their speech clearly, and often speech is quite difficult to listen to because it's so effortful and at times robotic, and the grammar's affected. And they've found that people with progressive non-fluent aphasia, their ability to recognise emotions has also declined. And as the illness progresses, that there is apathy or a lack of drive and motivation, and that they can become more inflexible and not have the same level of empathy. Generally, in the early stages to moderate stages of the illness, often it's just language changes and the behavioural changes come later, and they tend not to be as severe as in somatic dementia or behavioural brain FTD. And progressive non-fluent aphasia, some people can start having a language presentation of progressive non-fluent aphasia and then develop something like such as corticobasal along the track. So sometimes the lack of fluency in language can be the first symptom, and then the diagnosis can change slightly over time, or the symptoms can change. So what happens if people have difficulty paying attention? So what type of difficulties does that cause? So you can imagine if you're finding it difficult to pay attention, you can't follow through with a task, and you find it very difficult to multitask and sustain concentration for any length of time. And most people with BVFTD, their concentration span is reduced. So if you're expecting them to be able to pay attention to the same degree as they did before, it's going to be much more difficult. Executive functioning is moderated by the frontal lobes and the connections of frontal lobes to the other parts of the brain. And this is having difficulties with planning and organisation, being much more impulsive, disinhibited, having rigid thinking, and being unable to start or stop an activity. So the starter motor is broken and they can't work the brakes as well. We often say that the gates around the emotions are not working as well, so they can't filter what they say comes in or out as easily, and they can't check their own behaviour. So disinhibition occurs with some people with FTD, not all people, but certainly with a vast majority of behavioural variant have some level of disinhibited behaviour at some stage of the illness. And often it could be a lack of social tact, and they can act in a way that might be embarrassing for families. And we often talk about it with an inside thought versus an outside thought. So for someone that doesn't have FTD, they may have a thought that someone may be, for example, overweight, but they wouldn't say that. It's an inside thought. But for people with behavioural variant FTD particularly, those thoughts become outside thoughts. So they may talk about, make negative comments about people's physical appearance, about their race, about their sex life, about a whole range of things, or their religion or politics that they may not say in normal social situations. And they often find it really difficult to understand the other person's point of view, that the other person may not want to engage in sexual relations, or the other person may not want to go out with them, or may not want to have a conversation with them. They can't understand the body language and the changes that that causes, and they can't understand personal space. And they can't delay gratification for a long-term goal. Yeah, sure. So in terms of managing disinhibition, I think firm and consistent reminders that behaviour is not appropriate is often really useful. And we find distraction, redirection and humour is often really good. But it's important to think about some of the potential causes. So sometimes behaviour is an expression of an unmet need, not always in BV-FTD, but occasionally. So you need to think of, for example, is the person lonely? Are they being stimulated enough? Have they got enough activity? Other things that may be causing the behaviour. And try and avoid triggers as much as possible and make sure the person's getting enough exercise and physical activity to manage things such as agitation. With aggression, so aggression can occur when there's a lack of impulse control, and also if someone's very frustrated or humiliated, for example, that they may be more likely to be aggressive. So if you're asking someone to do something that they can't do anymore because they don't have the cognitive ability to do it, often they can get more frustrated and it's more likely that they'll become aggressive. They can't meet their own needs anymore, and they may also get very anxious, but their way of expressing anxiety or worry about being in a certain situation is to be physically aggressive because they might feel unsafe. So how do you manage aggression? So don't argue or rationalise, that's the first thing. There's no point trying to rationalise with someone that has behavioural variant dementia because they don't have the capacity anymore to be able to think in a rational, logical way. Distract where possible and make sure that your body language reflects the state that you would like them to be in. So, for example, if they're very heightened and they're quite feeling aggressive and out of control, you need to be as calm as you possibly can, lower your tone of voice, make sure your body language is not with your hands crossed, but, for example, your hands by your side, open, maybe go to the side of them so you're not front on, not confronting them. And these things can often reduce the tension in the room. Don't crowd or touch the person if they're being aggressive, and try and empathise with them as much as you can. And again, avoid triggers. And if it's safe to leave the person, if they're very aggressive, then just simply leave the room, and then you can try and identify the triggers after. If it's extremely unsafe and you're worried about your own personal safety, then you need to leave the room immediately and try and call the police or call an ambulance or get other family members in to support you as much as you can until they've got a chance to calm down. In terms of managing finances, look, I won't spend too much on this, but many people with BV-FTD and also other variants of FTD find managing finances very difficult, and they're much more likely to be exploited by other people in the community. So putting them on a do not call list and giving them only a certain amount of small money on a credit card, for example, so they can't lose too much money, is often useful because that still gives them some sense that they've got control of their money, but that they're not going to fritter away the family fortune. Shoplifting can be an issue, so we recommend people to shop local, be able to talk to the shopkeepers about the situation. Dementia Australia have companion cards where you can explain to the person that the person has dementia and that they may shoplift and then return the items afterwards. So what's apathy? So it's a lack of concern and motivation and a loss of interest and a loss of engagement. And it's probably one of the most common symptoms and the most debilitating symptoms in all forms of FTD. And it means if in the severe form that the person doesn't have the interest in doing their self-care anymore, that even things like showering and dressing, they are totally unmotivated to get along and do that. So this is when motivation occurs in normal people. So you can see here in the frontal areas of the brain and the striatum and the connections. Yeah. And apathy is divided into a couple of different types. So there's affective symptoms of apathy, behavioural symptoms of apathy, and cognitive. So affective may be a blunting, a loss of empathy. Behavioural would be withdrawn or inability to start or initiate behaviour. And cognitive is a lack of interest in routine, for example, and difficulty planning to achieve a goal. So there's been quite a lot of work in positive behaviour support, and that's been run out of Sydney and also Flinders University. I'm just going to show you the positive behavioural support manual, which is fantastic if you want to download it. It's on the web. So really it's talking about what can you do to make the behaviour a more positive experience for the person and engage them in things that they've always loved to do and support them to be able to do the things that they once did. So rather than doing it for them, setting them up and mirroring so they can mirror your behaviour. So if you're starting to do, for example, cooking a meal, You start alongside them, you set it up, for example, so the carrots are out there, they're nice beside it. You start chopping carrots and show them what to do, and then get them to support you as you go along. And that's the Positive Behavioural Support Manual by Linka Fisher, Claire O'Connor and Olivia Piguet. Okay. In terms of insight and indecision, so that is very common that people don't have much insight anymore. And when you're asking them, for example, do they want to do activity, often they'll say no, and that's because it's an overlearned response. It stems back right to childhood. Sometimes people with behavioural variant FTD and other forms can act more like a child in their behaviours. And so it's much more useful not to give them the option to say no, or if they do say no, don't assume that it actually means no, and minimise the number of choices that they've got. We often find that if you'd like someone to do a certain activity to increase motivation, offer them a reward, or for example, if you want them to go out on a social outing and you've been having trouble getting them to shower, link it. So for example, if they always get to go out to the cafe with a friend, make sure that they have to have a shower beforehand if there's a shower that you want them to have. So it's linked to a positive experience, more likely for the behaviour to occur again. In terms of circuit breakers, so sometimes things go wrong every day and it's just incredibly difficult to manage some of the behaviours. So we find that people can often use music or singing. Often people, even if they don't have much language left, are still able to sing if you play a favourite tune, or if you turn on some music that you both like or one of you likes. It can just lift the mood and just break the circuit if things are getting difficult. Laughing or crying or screaming in a cupboard or just making sure you've got some time out. And often things like aromatherapy and exercise and being in nature or going out for a walk, or either you or the person with FTD or both, can just break the circuit for that particular time. And make sure that you use, so if they've got particular types of behaviours or activities that they do repetitively, use them to your advantage. So if they like, for example, watching a certain show over and over again, use that if you need to have a break. So in summary, FTD is a brain disease and every individual with FTD is different. So all of the behaviour changes I've talked about today, not every person will have those changes. Some will have some will have others, and everyone's an individual, and who they were as a person before they developed FTD will impact how their behaviours are exhibited when they have FTD. It affects the whole family, and taking care of yourself is incredibly important.